Urothelial cancer is quite a diverse disease, and we encounter actually in clinic not infrequently quite a few different variant histologies. Most of the time, these are variant histologies that arise on the background of urothelial carcinoma. And so these are entities like, for instance, a squamous or sarcomatoid or plasmacytoid. Generally, again, they're present as a minority component with majority component urothelial. Sometimes, though, we do see a more extensive variant component as well. Separate from that, we also see basically non-urothelial cancers that arise in the bladder as well. And that could be entities like pure squamous cell carcinoma, sometimes pure neuroendocrine carcinoma, adenocarcinoma. Those are actually quite different. And we probably, from a therapy standpoint, approach them quite differently than the first category I went over. The first category, so again, variant histologies that arise on the background of urothelial cancer, these are, they certainly make us pay attention. I think, this is something where, when you see a patient like that in clinic, you zero in on this and you really think about, well, should I somehow approach this patient differently, than I would a patient with, pure urothelial histology. There are now, some trials to look at this question. Actually, Andrea Paulo at the NCI is running important studies there. There are other investigator-initiated trials as well. But I think we have some at least initial retrospective data from the UNITE study, the UNITE registry, where we looked at this question of whether, the sort of newer potent systemic therapy that we use a lot now for patients with urothelial and bladder cancer, namely EV and pembrolizumab, whether that works, as well for these patients with variant histologies. And at least in the metastatic setting, again, what we're seeing is that EV and pembrolizumab does have activity for these patients. So this is again, a retrospective analysis in the UNITE study that we did initially with looking at just enfortumab vedotin monotherapy, and we published this data earlier this year in European Urology. Now we have a study looking at the same outcomes in the same patients, but with the EV and pembrolizumab combination, and that is data we presented as a poster at ESMO just this past year. But what we're seeing is that actually enfortumab vedotin and pembrolizumab do have activity in patients with variant histology, though this activity does decrease as the extent of variant histology increases. So it's highest for patients who have mostly urothelial histology with a component of variant. If they have majority variant with a component of urothelial, then the response rates are lower, but they're still there. For pure variant histology, we see some responses with EV pembro, but they're much fewer for sure. Now, it is encouraging that we do see some responses, and that's why often for these patients, this is certainly a regimen that I would consider. A histology where perhaps we should be more cautious with this approach are a neuroendocrine or small cell bladder cancer patients. And because presence of that histology really unfortunately portends pretty poor outcomes, and I'm not as convinced that enfortumab vedotin-based regimens kind of work all that well there. As part of this question, you also asked about molecular subtyping. And that's an altogether kind of very different question. That's looking really at the molecular landscape and really the expression landscape in tumors and trying to basically classify them into groups, right? And these groups, can correlate somewhat with the presence of variant histology, but it's an imperfect correlation at best. Generally speaking, when we split patients into these molecular subtypes, there are luminal versus basal subtypes. This is, classification that initially comes from breast cancer, but it's been at least somewhat adopted in bladder cancer as well. But there, as a broader pattern of classification, there are now even different subtypes within luminal, within basal. There's also a separate neuroendocrine subtype. What we see is that, again, with luminal subtypes, there's more probably Nectin-4 expression. There's more of some of the other relevant alterations like FGFR3 alterations. Also, probably HER2 expression potentially is higher there. So, and most of our currently available therapies, certainly targeted therapies, would probably be directed at those subsets. Patients with a basal subtype are certainly in need of additional treatments and additional options. This is, again, just maybe a more general overview of this. I would say in clinic right now, we don't really use this to make decisions, but I think this is, subtyping these tumors is, potentially an important future approach that we should really kind of investigate in, prospectively investigate in clinical trials to see if there is a reliable way to identify patients who, again, based on molecular subtyping, who can respond to certain therapies versus those who won't, and where we should, consider other options.